大家好，我是周石，在澳大利亚的南十字星大学工作。在座的很多同事可能都认识我，因为我每年都参加这个华人运动生理和体适能学会的年会。这个年会从2002年开始，在台湾已经举办过3次，所以呢，跟台湾的许多同仁都有过见面，很高兴又见到老朋友，也很高兴能够与新的朋友进行交流。今天的主讲人呢是我的同事，澳大利亚南十字星大学的Mike Climstein 教授。下面我就用英文对他做一个简单的介绍。Now I'm introducing my colleague, Associate Professor Mike Climstein. Mike is a clinical exercise physiologist and has worked in a number of universities in Australia, including recently at the Bond University and the Sydney University. Currently, he is our course coordinator for our Master of Clinical Exercise Physiology degree. Mike is also a researcher with extensive research experience, and his research work has been published in 133 journal publications and 11 book chapters. His research is supported by more than $7 million Australian research fund. He is also a fellow of American College of Sports Medicine and a fellow of Australia Exercise and Sport Science and Sports Medicine Australia. And he previously also worked as a director of the Chronic Disease Rehabilitation Clinic. So now we invite Mike to talk about this topic.
Thank you.
Mike,
Thank you. Thank you, Professor Zhou. So chronic disease and exercise. So chronic diseases and conditions are the most commonly, costly, and preventable of all health problems, according to the Center for Disease Control in the United States. As you're aware, chronic diseases, the majority of which are preventable. However, with most chronic diseases, exercise has been shown to be highly evidence-based and effective. So it's used both in conjunction with either prescribed medications, it's used in conjunction either before or following surgical procedures, or as a standalone therapy, particularly in the prevention of a number of chronic diseases and disorders. And there's a number of studies that are available which actually show the effectiveness of evidence-based exercise and how that compares to prescribed medications. Next slide, please. Now, in Australia, the term accredited exercise physiologist, known as AEPs, they're university qualified allied health professionals. So that's the same recognition as nurses, osteopaths, podiatrists, physiotherapists, etc. So they have the knowledge and skills and competencies to deliver and evaluate safe, clinically effective, evidence-based exercise interventions for people with both acute, subacute, or chronic medical conditions, injuries, or disabilities. Most importantly is that they're able to screen their clients or patients to determine whether or not exercise is appropriate, and if appropriate, then they design individualized evidence-based exercise programs to help the individuals with their chronic disease or conditions. Next slide, please. Now, this is a study by Chang that was published in PLOS ONE that deals with morbid obesity in Taiwan. And the reason why we've included this slide is obesity is a very common comorbidity with a number of conditions. type 2 diabetes, heart disease, stroke, dyslipidemia, hypertension, etc. So it's important to evaluate obesity with regards to the population. So this study by Chang, they found the prevalence in overweight and obesity was established in 2 surveys. And you can see though that the morbid obesity, that means a body mass index, a BMI, of 40 kilograms per meter squared or greater. And we can see on the slide from the study that was conducted from 1993 to 1996, we can see a small percentage of those that were morbid obese. However, if we look at then the more recent study, which was conducted from 2013 to 2014, we can see that morbid obesity increased by over 3.5-fold. As important is obesity has also increased sharply. Now, with this slide, it doesn't specify ages, it only gives percent. However, we do know, though, in cases where there is childhood obesity, we know there's a very high likelihood that these children will be obese as adolescents and as adults. And unfortunately, that leads them to premature development of hypertension, elevated blood pressure, cardiovascular disease, type 2 diabetes. And if you remember, the name type 2 diabetes previously was called adult onset type 2 diabetes. However, they changed the name because of the obesity that we're seeing and sedentary lifestyles in young kids. We're seeing such a large increase in type 2 diabetes in young children and adolescents. Hence, they changed the name to just type 2 diabetes. Next slide, please. Now, this study by Fu et al. Are the trends in multiple chronic conditions in Taiwan. So, MCCs, multiple chronic conditions, are increasingly prevalent among the older, meaning 65 years of age and older population, and children and adolescents. So if you look at this slide, you can see the white bars represent individuals in Taiwan that have 2 chronic conditions. And then you can see the gray, and as the bars get progressively darker, it goes up to 5 or more chronic conditions. If you notice in 2000, we can see that there are individuals that had from 2 to 5 or more chronic conditions. However, if you now look at 2010, the most recent study that was done, and Fu reported this, you can see that the prevalence increase almost doubled in those with 2 chronic conditions, but more concerning are the individuals that have 5 or more chronic conditions has also doubled. Therefore, prevention and early intervention programs are clearly warranted, and that's where accredited exercise physiologists have an integral component and an important part to play in the Taiwan healthcare system. Next slide, please. So this study by Abdullah, published in Endocrinology in 2014, reports on the prevalence of type 2 diabetes in Asian countries. So Asia is developing as an epicenter of the escalating pandemic of type 2 diabetes, and it's reflecting the rapid transitions in both demography, migration, diet, and lifestyle patterns. You know, worldwide, we're becoming more mechanistic. You don't have to get up to turn the TV channel. There's a remote for that. In the car, you don't have to wind the windows down. You can use a remote, the electronic windows. When you go shopping, if you're at a mall, there's escalators to take you from one floor to the other. So that mechanism of society is leading to, and the changes in diet and sedentary lifestyle is why we're seeing such a large increase in type 2 diabetes, particularly in Asian countries. If you look at the figure that's shown by Abdullah, you can see that Malaysia has the highest prevalence at about approximately 11%, but you can see Taiwan is just over 8%. And this is an alarming fact, and we know that this is going to increase. And the problem with type 2 diabetes, of course, as soon as somebody has type 2 diabetes, the risk for heart disease and the risk for stroke is increased significantly. Also important are the risks themselves that are associated with type 2 diabetes. And that's microvascular disease, which means small vessel disease, blindness, etc., and macrovascular disease, which are large vessels, which we're referring to peripheral arterial disease, heart attack, stroke, hypertension, etc. More problematic with that, of course, is that we're seeing type 2 diabetes occur in younger and younger individuals. So type 2 diabetes mellitus has an enormous economic, psychosocial, and physical impact on individuals, their families, and also on the community. As I mentioned, the consequences of type 2 diabetes overall include vascular disease, that can be cardiovascular, stroke, or retinopathy, which is blindness, neuropathy, and the neuropathy, which unfortunately can lead to amputation. Next slide, please. Now, this is the Taiwan longitudinal study on aging that Zhou completed and published just this year. So this is looking at cerebral vascular accidents, CVA or stroke, and cancer, and they lead to disability immediately. So conditions such as diabetes, cancer, hypertension give rise to higher increments of physical disability in later stages of the disease. Now we know that individuals can have a stroke, cerebral vascular accident, and we know that they can have mini strokes, which are transischemic attacks, and the person can suffer no disability whatsoever. However, they can have strokes which can either lead to partial or full paralysis, and that paralysis can either be short-term or it can be permanent. And so much so that the literature shows that the physical abilities regained in the first 6 months following a stroke are about 95% of what that person can gain back. That's why hypertension, for example, is such a problem because of its increased risk for heart attack and for stroke. So therefore, physical activity and exercise, and most importantly, evidence-based exercise programs are critically important in the prevention of elevated blood pressure. Also with elevated blood pressure, unfortunately, is additional wear and tear on the kidneys. So in chronic kidney disease, for example, individuals end up with worsening kidney function where they end up either on dialysis, which requires them to attend a hospital facility usually 3 days a week for 4 hours at a time, or if they end up in end-stage kidney disease, they end up needing a kidney replacement or kidney transplant. And the difficulty with that is, whether it's in Taiwan, whether it's here in Australia, is there's limited donors that are available. And all of this goes back to simply elevated blood pressure. Although kidney disease is also related to and very common in diabetics. So you can see the importance of maintaining a normal blood pressure, and hence why physical activity and a good diet, exercise, is critically important. Next slide, please. So this is the aging and chronic disease in Taiwan, and this is from your Health Promotion Administration, the Ministry of Health and Welfare. So this year they found that just over 16% of the population in Taiwan is aged over 65 years. And this is common both through Australia, the United States, through Canada as well. However, your Health Promotion Administration has set metabolic syndromes, diabetes, cardiovascular disease, and kidney disease, amongst others, as the prevalent foci of chronic disease that needs to be addressed. And, individuals can have a family history or genetics that predispose them to developing diabetes, cardiovascular disease, etc. However, that is a non-modifiable risk factor. However, with regards to exercise, diet, physical activity, they are modifiable risk factors, similar to smoking, maintaining a normal body weight, etc. Next slide, please. So this is still from the Health Promotion Ministry program, and it set the following preventative goals. So improvement and maintenance of health in middle-aged elderly people. And remember, this reduces the personal financial cost for these individuals. It reduces the cost to the government, but also leads to a higher quality of life for these individuals that are affected or can be affected by these chronic diseases. Prevention and delay in the occurrence of chronic disease. Again, that lessens the cost to the individual. It allows the individual with a number of chronic conditions to continue in the workforce without having limitations, the cost of medications, and also the cost to the government. And overall, it enhances the quality of life for the individuals, the patients, their family members, and also the caregivers, which are typically family members as well. And that reduces the burden on the family as well. Next slide, please. So, the Health Promotion Administration has 3 highs. They want to focus on hypertension, prevention, and treatment of hypercholesterolemia, which means elevated cholesterol, or a low HDL, which is the protective cholesterol, and hyperglycemia, which means elevated blood sugar, and that's in the prevention of prediabetes, but also in the development of type 2 diabetes. We know that from the research, individuals with prediabetes, whether it's impaired fasting glucose or impaired glucose tolerance, if an individual has one of those prediabetes conditions, we know there's a very high likelihood without any intervention that they are going to develop full-blown type 2 diabetes. And the problem with that for most individuals is we have tablets, they're called oral hypoglycemic agents. They're effective in controlling blood sugar, along with a low glycemic index diet and regular physical activity or exercise. However, once you start on the orals, sorry, can we go back one slide? Thank you. Once an individual starts on those oral tablets for diabetes, we know that in roughly 10 years, insulin is going to have to be added to their medication regime to keep their blood sugars well controlled. Because if the blood sugars are not controlled, so in Australia we measure that through what's called glycolated hemoglobin, and that's commonly referred to as HbA1c, it should be 7% or less. If it's not, the blood sugars are not well controlled, then we know that there's an increase in both the microvascular and macrovascular complications that are associated with diabetes. Next slide, please. So if we look at the national survey, I was talking about HbA1c, it's also abbreviated A1c, blood pressure and control. This was published by Wang et al. In the Journal of Formosan Medical Association. With regard to those 3 HbA highs, they found out within Taiwan that hypertension, 25% of men, 18% of women, and 47% of Taiwanese aged 60 and over had identifiable or measured hypertension. With regards to hypercholesterolemia, Chim did a study in 2005, and they found that elevated total cholesterol was found in over 36% of males and 27% of females. We know that an elevated total cholesterol is a primary risk factor for heart disease, for stroke, and also for vascular disease. Those diseases are called atherosclerotic diseases, and cholesterol is a primary risk factor for that. With regards to hyperglycemia leading to type 2 diabetes, 14 in 100,000 Taiwanese were identified as having hyperglycemia. So again, this is within the target areas that has been set by the HPA. Next slide, please. So if we look at accredited exercise physiologists, what about the benefit to cost ratio? So Delete Economics in 2015 conducted a study, and they found out that exercise interventions conducted by accredited exercise physiologists are estimated to be both clinically effective but also highly cost-effective in the Australian healthcare setting. That includes people that have pre-diabetes, type 2 diabetes, depression, and cardiovascular disease. This finding and this cost effectiveness aligns very well to the Health Promotion Administration and the Ministry of Health and Welfare in Taiwan. Next slide, please. So what about evidence-based exercise interventions and their effectiveness? So exercise interventions delivered by accredited exercise physiologists have been estimated to reduce the incidence of type 2 diabetes in high-risk populations by 31%. So who represents a high-risk population? So we know there's a number of ethnicities that are known to be at risk. If you've got a family history of type 2 diabetes, the individual is more at risk. If the person has an elevated body mass index, they're known to be at risk. If they also have elevated blood sugars, they're also known to be at risk. Now, with regards to cost effectiveness, the annual savings to the Australian health system is over $5,000 per person for type 2 diabetes and $2,000 per person for prediabetes. So in this country, the government subsidizes prescribed medications. The same thing for hospital visits and doctor visits. So with all of those costs, there's a significant savings to the healthcare system. However, there's also a significant savings to the individuals because it's not fully funded by the government. So that saves individuals monies towards what they have to spend to see their doctor, if they're hospitalized, or if for their prescribed medications. Next slide, please. Now, this is the benefit to cost ratio study, and you can see that for every dollar cost, you can see that the benefit to cost ratio for pre-diabetes was 6-fold, for type 2 diabetes was greater than 8-fold, for depression almost 3-fold, and for cardiovascular disease over 6-fold. So I looked up some further information from this study and found out musculoskeletal injury, particularly chronic low back pain, was over 14-fold benefit, osteoarthritis 4-fold, and rheumatoid arthritis over a full 4-fold benefit to cost ratio. So the exercise interventions in chronic disease management are proven to be cost effective, and that is a very strong justification for implementing clinical exercise physiology into healthcare systems. Zhou?
前面呢，这个Climstein 教授呢，回顾了一下这个运动锻炼的体力活动在防治疾病和治疗疾病以及运动康复这个里边的作用，而且呢，结合了台湾的一些现状做了一些这个评论。那这样呢，这个运动既然这么重要，对促进健康啊、防治疾病啊这么重要，那么怎么来做这个事儿呢？政府和地区啊都做了一些这个工作比如说很多专业团体和这个政府呢都推出了怎么做这个适当的身体活动的指南，在台湾他们叫指引，包括这个台湾卫生福利部国民健康署在2018年最近推出的这个全民身体活动指引，但是呢，这个民众里面参加适当体育活动的比例呢还是很不够的。比如说在2019年，台湾的一个数据呢说，有规律参加运动的人口现在只有1/3左右，男性的参加规律运动的比例稍高，但是女性呢稍低。这样的话呢，就是咱们作为运动科学和运动生理工作者呢，还有大量的工作去做，促进民众呢参加身体健康。但是今天要讲的这个主要内容呢是关于怎么来为一些高风险的人群做服务，比如说有疾病的人群， 或者是老年人，怎么做适当的这个体力活动。大家都可能听说过这个运动是良医这个说法，就是 exercise is medicine， 这个是由美国运动科学学会发起的一个全球性的这么一个活动。台湾呢也参与了这项这个活动，也有这个台湾的 exercise is medicine 的这么一个组织，他们也发表了一些针对一些特殊人群的身体活动的指引，这个是很好的一件事情。但是呢，还是很不够的，就是还需要继续做大量的工作。下面呢要讲一下，就是这些做这个运动指导运动和这个为特殊人群或者说是有高风险人群做运动指导，这些专业人员是怎么培训出来的？下面这个Mike Climstein 教授呢将介绍一下这个关于临床运动生理学家培养的一些细节。在这之前呢，我介绍一下，就是在2-3年以前，我们一些学者，包括澳大利亚，还有这个中国大陆、台湾和香港的一些学者呢，对这个澳大利亚和中国运动科学专业人员的在这个医疗保健系统里边的作用啊，做了一个调查，做了一些比较。咱们可以这样认为，就是参加体育锻炼的人群呢，大概可以分成3大类。一个呢是健康人群，就是普通的民众参加体育锻炼；再一种呢是有疾患的人群，就是 clinical population， 他们有一定的伤病这些人怎么进行锻炼？再有呢就是高水平的运动员，为了提高运动成绩，怎么来进行适当的这个训练和这个体能的提升。所以呢，关于这3个大人群呢，今天咱们要谈的主要是这个 clinical population， 也就是咱们说的 clinical exercise physiologists， 他们是怎么培训的？他们在社会上有什么作用？这里就是先强调一下这个澳洲做这个培训的一些特点。大家可以看到呢，澳大利亚的这个做 clinical exercise physiology 的这些人呢，基本上都是由这个大学直接培养出来的，这个就需要有或者是4年制的学士学位，或者是3年制的学士学位加上1年到1年半的这个研究生学位，这样培训出来的这个人才。这个和中国大陆是不太一样的。中国大陆呢，关于这个运动治疗师啊，他们有一个名词叫运动处方师，这个是刚刚最近几年才开展的一个培训活动。这些呢不是直接由这个学士、硕士、研究生这样培训出来的，而是呢就现有的已经毕业的这个运动科学工作者，或者是医务工作者，他们想做运动治疗，就是对他们做一些基本的运动处方方面的培训，都是一些短期的培训。我了解到就是台湾的一些有关的从业者，这个毕业生，他们也有机会去大陆参加了这方面的培训，但是在台湾本身呢，包括香港呢，目前还没有这方面开展培训。有这个在大陆有一些这个大学出来的培训的这些有关的工作者呢，叫这个运动康复师，就是在医院里工作的，这个做一些基本的康复治疗的，这些呢是需要有学士学位或者是研究生学位，这个水平的培训的，但是呢做这个临床运动生理治疗或者是指导这个有高风险人群的这个运动，他们还是没有在这个大学的层次做这个学士或者是研究生水平的培训，所以这是一个很大的不同。 其他2个人群，咱们现在今天就不详细的讨论了。下面呢，这个由Mike 来继续探讨，就是在不同的国家，包括美国，是怎么样培训这个临床运动生理治疗师的。Now, Mike, you take over.
Thanks, Professor Zhou. So, the American College of Sports Medicine offers a number of accredited programs. What's important here is to differentiate that these are accredited programs. They're not university degrees. Okay? So, there's different prerequisites to sit. So, for example, a health and fitness stream, they have a personal trainer and they have an exercise instructor, and individuals can sit for those accreditations with just simple study, but they're not required to have an undergraduate degree for that. However, their clinical exercise physiologist accreditation requires an undergraduate degree in either exercise and/or sports science or exercise physiology. They also offer now specialty credentials, which is exercise as mentioned, and as Professor Zhou mentioned to you, Exercise is Medicine runs programs in Taiwan. They have very good educational information out for patients with a wide range of chronic diseases as conditions. There's Exercise is Medicine Australia, Exercise is Medicine, which ACSM started in the United States, and there is Exercise Medicine Canada and elsewhere around the world. So it's very popular program. Their specialty credentials also include cancer exercise trainer. As you know, the prevalence of a number of cancers, particularly breast cancer in women and prostate cancer in males, there's such a large prevalence of that in the world that they've come up with a accredited program stream which addresses that. And there's also universities that are offering here in Australia graduate certificates in Exercise is Medicine Cancer. And then they're also offering a accreditation in physical activity in public health. And that was designed to meet the problem of sedentary activity and all the chronic conditions that are associated with having a sedentary lifestyle, both in adolescents, young adults, and older adults, and in the community. Next slide, please. Now, the ACSM certification exams are either national or international exams. So, for example, here in Australia, in Taiwan, anywhere in the world, there are exam organizations. You sign up, you go online, you must have a webcam, you sit the exam online. For the clinical exercise physiology certification, there's 225 multiple choice questions that cover 35 plus chronic conditions. So it's based on recall from information that are available in their guidelines for exercise testing and prescription book. This is the new version that's out. They also have other study guidelines which are available, resources, sorry. It's based on application and then, of course, synthesis for information. For that particular certification, you can see that the performance domains, the weightings, 20% is on assessing the patient, and risk assessment is highly important with regards to prescribing exercise to make sure it's appropriate and it's safe. You need to be able to recognize the contraindications to exercise for any individual, and that's both relative and absolute. There's exercise testing. There's also exercise prescription, exercise training and leadership, education and behavioral change, and legal and professional responsibilities. And those different weightings help guide individuals in terms of studying. Next slide, please. Now, there are disadvantages to the ACSM certification exams. Now, this is, in my opinion, based on the Australian system, where it's really only recognized in the United States. So if an individual comes from the United States to here in Australia and they want to get accredited by our accrediting body, they don't accept it. So they have to go through a mapping exercise. They have to demonstrate that they've got practical experience working in clinical exercise physiology. It's also difficult in preparation. There's thousands of universities in the United States, and they're all taught differently. So unfortunately, those universities aren't privy to everything that's on the exam, only its content is taken from a number of the American College of Sports Medicine publications and resources. And that makes it difficult to teach students at the tertiary level, at the university level, to prepare and pass these exams. But also a significant weakness is the competencies aren't assessed. So for example, this session at Southern Cross University, our students are doing a unit of study called cardiovascular health. And within that particular study, they're learning about electrocardiography. They learn to identify arrhythmias. They know which arrhythmias are life-threatening, which arrhythmias are not life-threatening, and then how to conduct submaximal and maximal graded exercise tests. That's not only on a treadmill or a bicycle, but for example, how do they conduct a 6-minute walk test? How do you conduct it on an arm crank ergometer for somebody that might have either lower limb injury or lower limb paralysis, for example? Next slide. Now, this is, pardon me, this is the Exercise and Sports Science Australia model for their accreditations. So let's look at the far right, and you can see elite professional sport, transitioning athlete going from semi-professional or retiring. Those individuals, students that are interested in attaining that qualification, become accredited sports scientists. And there's coursework which specifically maps out the theory and practical components, the competencies that are required to work with elite sport. Now we'll go through the center part, which is called the apparently healthy exerciser. And that's our exercise scientist. So here at Southern Cross University, students complete a 3-year degree. Professor Zhou will highlight the different domains that they have to study in. And they're trained to work with the apparently healthy. Now, if we go over to the left and we look at individuals that have a low risk of pathology or injury, or they're at high risk, or they're diagnosed with cardiovascular, metabolic, respiratory, neurological disease, those are all the domains and the scope of practice for a clinical exercise physiologist, or what ESSA refers to as an accredited exercise physiologist. And again, as I mentioned, they're recognized allied health professionals in Australia. Next slide. So what are those ESSA accredited programs? So starting at the undergraduate level, there's exercise science, exercise physiology, which is the focus of our topic for this presentation, and that's postgraduate study. There's sports science, and there's also high performance managers. So ESSA offers accredited programs for all of these, and the way it works in Australia is ESSA sets up theory and competencies that must be taught in your program, and then your program is accredited. And you have to meet 100% of the ESSA criteria and competencies for your program to be accredited. And then once it's accredited, graduates from your program then graduate aside from their bachelor's degree or master's degree. They're accredited either as exercise scientists, as exercise physiologists, etc. Next slide, please. So with regards to the exercise physiology accreditation, firstly, you have to have an undergraduate degree, an exercise science degree, which is ESSA accredited. Then you need to complete through a master's degree the accredited exercise physiologist standards. Now, something that I don't have on this slide, at the exercise science standard, that includes 140 hours of practicum experience with apparently healthy individuals. So they have to prescribe exercise, they have to be able to deliver safe and effective exercise interventions. However, at the accredited exercise physiology level, there's a minimum of 360 clinical hours of practicum that's required. So to become an accredited exercise physiologist, you end up having to be an exercise scientist first, then complete your degree in exercise physiology. You have to have 140 hours minimum of experience with apparently healthy clients or patients, and you have to have at least 360 hours minimum with clinical populations. So that means you're going to have a minimum upon becoming an exercise scientist of 500 hours of practical experience. Next slide, please. Now, within the exercise science, there's 15 domains. So when you study to become an accredited exercise scientist, the program includes study of biomechanics, exercise delivery, exercise prescription, exercise physiology, functional anatomy, human growth and development, health, exercise and sport assessment, health, exercise and sport psychology, human anatomy, human physiology, motor control and learning, nutrition, physical activity and health, professional practice, and research methods and statistics. And of course, the 140 hours practicum on healthy individuals. You'll notice that there's an inclusion there of research methods and statistics. That's because either as an exercise scientist or you'll see as an exercise physiologist, students must be able to identify high-quality research findings, similar to what Professor Zhou and I presented earlier in this presentation, and be able to disseminate that information in terms of how it applies to evidence-based practice with either apparently healthy clients or clients or patients that have chronic diseases or conditions. Next slide, please. Now, with regards to exercise physiology, there's professional practice, foundational knowledge, referrals, screening, and assessments of exercise capacity, design of evidence-based exercise interventions, implementation of exercise and health and wellness interventions. There's then the different domains. So for example, cancer domains. So breast cancer, colorectal cancer, prostate cancer, all the different cancers, cardiovascular domain, kidney domain. And in the kidney domain, we're really talking about the 6 different types of kidney disease. Mental health domain, metabolic domain, musculoskeletal domain, neurological domain, and respiratory and pulmonary domain. And as I mentioned earlier, the students are required to complete a minimum of 360 hours practicum. Now, when the exercise physiologists have completed all their coursework and their practicum, then they have to sit what's called an OSCE exam. So they get a patient that they haven't seen before, and they're graded upon how well they can apply all of this information, the physiological tests, the understanding of the results of those tests, and then the development of the exercise prescription for the patient that they've seen, which will typically have comorbidities, meaning they just won't present with cardiovascular disease. They may be obese, they may have cardiovascular disease, they may have had a stroke, etc. Next slide, please. So when we look at those target pathologies, just to give you an example, cancer, I mentioned breast prostate, bowel cancer. With regards to cardiovascular, it's quite a big domain. It's ischemic heart disease, acute myocardial infarctions. They have to learn about STEMI and non-STEMI. They have to learn about biomarkers for determining if somebody had a heart attack in line with electrocardiography. Chronic heart failure, arrhythmias. They have to understand pacemakers and implantable defibrillators, hypertension, peripheral arterial disease, and valvular disease. Then kidney, I mentioned there's a number of different kidney disease. So chronic kidney disease, they have to be able to understand that the glomerular filtration rate determines the stage or the severity of the kidney disease. There's diabetic nephropathy. And basically that's kidney disease that's associated with diabetes. There's hypertensive neuropathy, which is kidney disease that's associated with elevated blood pressure. Polycystic kidney disease, and then long-term medication use, infectious kidney disease, acute kidney failure, there's reversible, and then there's end-stage kidney disease, which I mentioned. They either have to undergo dialysis to continue living, or they need a kidney transplant. Then there's the mental health domain, where they're given information about anxiety disorders, affective disorders, psychotic disorders and trauma, and stressors related to disorders, and how evidence-based exercise is highly beneficial with regards to the treatment of mental health disorder. There's metabolic disease, so we look at overweight and obesity, metabolic syndrome, dyslipidemias, and that's acquired and familial. So for example, we saw a patient the other day here in the clinic. He was 50, very active, avid runner, swimmer, etc. But his LDLs, low density lipoproteins, were quite elevated. He had a very good diet. However, come to find out, his sisters, his brothers, his parents all have elevated LDL. So when it's genetic, it's called familial dyslipidemia. Acquired means generally they have a diet that's high in saturated fats. They learn about type 1 diabetes, type 2 diabetes, gestational diabetes, sleep apnea, and polycystic ovarian syndrome. Then there's musculoskeletal disorders and conditions. So osteoarthritis, rheumatoid arthritis, osteoporosis, acute and subacute and chronic specific and non-specific musculoskeletal pain, injuries, and disabilities. Because Taiwan, like Asia, has an aging population, your likelihood of having osteoarthritis, osteoporosis, and osteopenia, which is a precursor to osteoporosis, is going to be quite prevalent in your population. There's also, they learn about neurological and neuromuscular disorders. For example, stroke, spinal cord injury, Parkinson's disease, cerebral palsy, multiple sclerosis, dementia, and traumatic brain injury. And then lastly, we have respiratory and pulmonary, asthma, COPD, chronic obstructive pulmonary disease, cystic fibrosis, emphysema. And because of the prevalence of smoking in the Australian society, we have a large segment of the population who are smokers for a number of years, and they present with varying severities of emphysema. Next slide, please. Now, with regards to the accreditation, the practicum requirements, to ensure that the students are well-rounded in the patients they can work with upon graduation, they require that the students gain a minimum of, for example, 200 hours with cardiovascular, musculoskeletal, and the metabolic domain. They then have to get 100 hours in cancer, kidney, renal, mental health, neurological, or respiratory or pulmonary, and then they have 60 hours of their choosing. These hours have to be supervised by an accredited exercise physiologist. However, they are allowed to go into placements with physiotherapists, which is good for improvement in musculoskeletal disorder. They can go into pulmonary rehabilitation clinics, etc. Next slide, please. So what about the clinical training? So with regards to fulfilling those practicum hours, here at Southern Cross University, we have a health clinic at both our Gold Coast campus, which is where I'm located at. Professor Zhou is located down at our Lismore campus, which is about an hour to the south. So we get patients referred in from the local hospitals, from local rehabilitation programs, for example, cardiac, pulmonary programs, stroke programs, fracture programs for osteoporosis. Then the students do risk stratification to determine whether the patients are at low risk, medium risk, or high risk. They then do observations where they learn to take blood pressure, resting and exercise blood pressure, heart rate. They learn about oxygen saturations. They learn to conduct resting ECGs. And then, of course, there's the assessments. And the assessments are specific to the different domains or the pathology of the patients that they see. So, for example, if somebody has a respiratory disorder, they're taught how to conduct spirometry and interpret the spirometry, which is lung function. They're learned to do cardiovascular fitness tests. They're learned to do musculoskeletal assessments. We get a lot of mature-aged individuals that, because of their occupation, they have shoulder injuries. So they learn how to basically assess the shoulders for either impingement, or they've got arthritis or different conditions, and then what evidence-based exercise is the most appropriate to help those conditions. Next slide, please. Now, with regards to the clinical training, when the students start, they're novice. So they've completed their undergraduate degree and they've learned the basics. So for example, they know how to do a body mass index, how to calculate it. They take the patient's height divided by their weight, etc. They do a waist to hip ratio. They learn how to do skin folds. Professor Zhou, can you tell them the ISAC qualification that you have?
ISAC 是一个国际上的一个关于人体测量学的组织。这个组织呢，就是为测量人体的形态，包括这个身高、体重、维度，还有这个骨的宽度和这个皮褶等等，有一系列的这个标准的测试方法。这个是澳大利亚和这个新西兰啊。一些学者首先发起的实际上还有这个英国的这个苏格兰，一些学者一块儿发起的。现在呢，这个全世界有30多国家来，已经采取了这个ISAC 提出的这种测量标准。Okay.
Thank you. So Professor Zhou then teaches our students to that level how to accurately conduct skin folds, because they're fairly non-invasive, they're easy to conduct, and the skin fold calipers, depending upon the quality that you want to buy, can be relatively inexpensive. They learn how to do a 6-minute walk test, but most importantly, conduct it safely, what observations they take. So for example, before the participant starts, resting heart rate, resting blood pressure, and oxygen saturations. And then every minute they're checking the heart rate and the oxygen saturations to make sure they don't desaturate. At the conclusion of the test, they get a peak heart rate, they get a rating of perceived exertion, they get a peak exercise blood pressure, and if they have any breathing difficulties, they get a rating of perceived dyspnea, which means labored breathing. They learn how to conduct a wide number of submaximal treadmill and bicycle tests, and they learn those protocols. Most importantly, they learn who is eligible to undergo those particular tests, and then what is the test termination criteria to make it a safe test for those individuals. They learn sit to stand, timed up and go, etc. Then they are a progressing novice, and then they learn how to do arm crank tests and other functional tests. Then they're a progressing intermediate. Now they're all, remember this whole time, they're under training by clinical supervisors and instructors to make sure they're learning how to do these tests precisely. and then they become entry level. And once our students have become entry level and can complete everything that you see on the slide, we've now prepared them, or as we say, work hardened, so they can go out and gain employment as an accredited exercise physiologist. Next slide, please. So, accredited exercise physiologists, their working environments include public and private hospitals, primary, secondary, and tertiary healthcare clinics, private and multidisciplinary medical clinics. And by multidisciplinary, we mean there's a physiotherapist there might be a speech pathologist there, a podiatrist, etc. Community health centers, workplace or occupational health. A number of our students are employed. Mining is a big industry in Western Australia. They go out to remote regions where people unfortunately experience a number of workplace accidents, and they rehabilitate those individuals so they're able to return to work. Aging and aged care facilities, fitness centers, and gyms. Next slide, please. Zhou?
OK，前面的这个Max 教授呢，给大家介绍了一下这个临床运动生理治疗师的一些这个培训和这个服务的这个方式。这里边呢，我就把这有关的一些这个临床运动生理治疗师的这个职责范围翻译成了中文，大家可以看一下。这些有关的资料呢，在这个澳大利亚体育运动科学协会的网站上都有，就是下面这个网址。这里边呢，我只是翻译了这个临床运动生理治疗师的职责范围 （scope of practice）。这里边就简单说一下，他们主要呢是要筛查、评估和应用临床推理，以保证安全和适宜的运动和身体活动干预。其中包括了进行生理学的测量，就刚才麦克提到的，像这个有氧能力啊，这个肌肉的这个力量和耐力啊等等这方面的测试。评定所有年龄段，从小孩一直到老年人，不同健康和体能水平的个体的运动能力，做出安全有效的针对个体情况的运动治疗方案。提供促进健康的教育建议和支持，包括与国家营养指南有关的处方药和这个有关信息一致的营养咨询，并且呢为有慢性病或者损伤的高危险因素的人群提供运动干预和教育，为已患有慢性病和并发症的或者损伤的人群提供临床运动处方。为患有急性或者次急性损伤，手术以后或者在恢复期的病人提供以运动为基础的康复治疗和建议，以恢复功能和生活质量。以上呢可以在初级、中级、高级任何水平的卫生保健系统中，这个以雇员或者志愿者的身份为个人或者社会团体或者人群提供服务。这里边就提一下这个职业的翻译，我这里翻成临床运动生理治疗师或者是临床运动治疗师，以区别于咱们平常说的这个作为运动科学基础学科之一的运动生理学。这个是指的在临床上应用这个运动作为治疗干预的一个方法，这个职业。这个翻译大家不知道是有什么其他的建议或者是考量啊？这个是可以探讨的。但在澳洲呢，如果提到 exercise physiologists， 实际上都是指的临床运动生理治疗师。Okay, back to you, Mark.
Thank you. So, what are the advantages to the S-accredited program? So, one, it's national certification. So, those individuals that are accredited can work anywhere in Australia. And now New Zealand and I believe the UK are recognizing the exercise physiology accreditation. It's a requirement for preferred positions. If you go on any of the job advertisement sites, it will state AE exercise physiologist required. There's standardized accreditation theory and competencies. So from Professor Zhou and myself, for us to teach it, ESSA specifies you have to cover this, and this. And we make sure that's included in the information that we provide to students, both in lecture format, in problem-based learning, but also in competencies that they have to learn. And there's a heavy emphasis on competencies, which is very good because it means the students upon graduation are work hardened. So they can go out and they can start to work with clients or patients that have various chronic diseases or conditions. And employers like that because that way they go out and they can work straight away. You know, yes, their early career and they will continue to learn as they go, but for employers, they know they can start to work with their different clientele, which is a very large advantage. Next slide, please. So what about clinical training? So as I mentioned, we've got clinical training facilities both at Professor Zhou's campus down at Lismore and here at the Gold Coast. So the students learn a wide range from selectorized pin-loaded equipment, bands, aerobic equipment, you know, treadmills, bicycles, etc. And they design individualized exercise programs under the direct supervision of an experienced exercise physiologist. We call them the clinical supervisors. And on campus, we're able to teach them the highest standard of how to work with their patients. And it's invaluable, and it probably is the integral part of the degree that we offered. Next slide, please. So why have accreditation? So overall, the benefits of accreditation include: one, it promotes improved patient and client outcomes and care. And ultimately, if you're working with what we would call vulnerable individuals, those are individuals with chronic diseases or conditions, really we want the best outcome from them. We want that for them personally. We want that so they're not a burden to their family. We also want it so they can continue gainful employment, but also the government wants that so that way there's reduced healthcare costs. It also mitigates risk by having an accreditation. So you don't have somebody in one area learning to do a test a particular way, which might be wrong and dangerous. This way you learn to do, for example, the Bruce treadmill protocol. And you learn this is how you do it, this is how it's done correctly. Skin folding, as Professor Zhou spoke about, how do you do it correctly? And then there's increased community confidence because you know you're dealing with somebody who's accredited. And then it also identifies strengths and gaps in training programs. They continually update the accreditation criteria we have to provide, and that's based on new evidence that comes out in the scientific and medical literature, and that is then included in the accreditation requirements, which then filters down to us, and we have to provide it in our coursework or our competency requirements. Next slide. So it also promotes a culture of high quality and safe practice so that people in Australia know if you see an accredited exercise physiologist, you know you're going to get high quality, effective care. It also lends prestige to institutions and its accredited members. So for example, here in Australia, if our undergraduate degree, our Bachelor of Sport and Exercise Science, or our Master of Clinical Exercise Physiology programs were not accredited, we would not have students that would sign up for our programs. It's a requirement, and they have to have that accreditation to gain employment. So it's just a must-have. There's shared policies, procedures, and best practice from the association down. And also it accredited individuals can practice at an established level, meaning that once they go out and they gain employment in the workplace, whether it's at a medical clinic, it's at an hospital, etc., or they go into practice for themselves, the standard of care that they can deliver to their clients, their patients, etc., is at an established level, and you know you're going to get good outcomes with the clients or patients. Next slide, please. So this is what our program looks like. So it's a 2-year program, and you can see in the first year, so on the far left is year, the second column over is the semester, and then the unit and the unit name. So they learn advanced sport and exercise psychology. And you might wonder, well, why sport and exercise psychology? Unfortunately, a lot of the problems of the chronic conditions that we see, you can say are self-inflicted by either sedentary lifestyle, poor dietary habits, etc. So to change someone's behavior is very challenging. So they learn about the trans-theoretical model, for example, and they're able to determine the stage or the likelihood that the individual will adapt to a change in recommendation. Then there's exercise physiology for specific populations. For us, that means kidney disease, cancers, and respiratory disorders. Metabolic health, diabetes, and a whole other host of disorders. And then there's small business and entrepreneurship, because they need to learn about the costs and benefits related to business, particularly if they want to go in and be what we would call a sole or private practitioner. Then there's cardiovascular health. There's clinical exercise for chronic conditions. And then the advanced professional practice 1, that's their practicum placement, where they go out and they complete a minimum of 180 hours with clinical supervision in the SCU health clinics or in external placements at hospitals, etc. And then in their last session, they learn about musculoskeletal health, they learn about neurological conditions, and then they have their second placement of a minimum of 180 hours. At Southern Cross University, we have found that it's highly effective, and the students prefer to learn about the different pathology domains that we have to cover when it's specific in units of study rather than spread out. And personally, we find it easier to teach that way because we know the requirements to meet accreditation are specific to the domains, and that way we can embed that within each particular unit of study. Next slide, please. Zhou?
Sorry. Okay, the last 2 slides. 这个前面呢，Mike 教授呢给大家介绍了这个临床运动生理治疗师的培训，特别是在我们学校有课程的设置。下一步呢就是通过这个学会这个年会的交流啊，我们也希望呢以后能够在这方面呢开展一些这个进一步的合作和交流。怎么样来在台湾，比如说大家如果有兴趣的话，或者是政府有这个需要的话，怎么来进一步的发展临床运动生理治疗师这个专业或者是这个职业。一个呢就是因为澳大利亚呢已经有比较成功的经验，就是澳大利亚的体育运动科学学会对这个临床运动生理治疗师呢有一系列的这个他们的职业标准。同时呢，也有对大学课程，因为这些专业人员都是从大学里培养出来的，所以呢，对大学的课程呢，也有一些这个很成熟的这个课程的评估认证标准。所以呢，如果咱们要是有兴趣进行合作呢，可以比如说某些同事是从这个大学里边来的呢，我们可以对两方面大学的课程做一些对照，然后呢从里面看哪些有共同的地方，哪些有这个互相不一样的地方，然后看怎么能够根据台湾的具体情况呢来设置一些有关的课程，培训有关的专业人才。这个就再简单的说一下，就是澳大利亚南十字星大学呢现在有关的学士学位，叫这个体育运动科学学士。 同时呢也有这个临床运动生理学的硕士学位。在前面已经提到了，这个马克教授呢是我们这个硕士学位的这个负责人。这个2个学位呢都是得到了澳大利亚体育运动科学学会课程的这个资质认证的。所以这些毕业生啊，如果是从这个体育运动科学学士这个课程毕业的呢，可以直接被认可为澳大利亚体育运动科学学会有资质认证的运动科学工作者，那就是 AES Exercise Scientist。如果是从我们的这个硕士学位课程里边毕业的呢，就可以被认可为AEP， 就是 Accredited Exercise Physiologist。这个呢，就他们毕业以后呢，就直接可以去到社会上开业找工作。那么 AES 呢，它主要是针对健康人群服务的，也可以协助 AEP 做一些这个对风险比较低的有疾患的人群的运动治疗。AEP 呢，就是主要是针对高风险人群的有疾患的这些人群的这个运动治疗或者是运动干预。就是这样的。这个澳大利亚当然跟台湾的许多学校和学者都有这个不同水平的联系。这里就简单提一下，就是在2018年呢，澳大利亚体育运动科学学会的主席和他的 CEO 呢，有机会到台湾来访问，就是参加了咱们华人运动生理和体适能学会的年会。同时呢，在这个过程中呢，也和这个台湾的运动生理及体能学会呢进行了初步的交流。现在呢还是希望能够进一步发展2个学会之间的交流合作。同时呢，从我们这个高等院校的水平呢，也希望能够在培养这方面的有关的人才方面做一些合作。所以我们学校至少是这个南十字星大学吧，我们是很希望能够和台湾的这个有关的院校的学者，或者是这个学位做一些这个交流合作，包括这个科学研究等等。以上呢就是今天要谈的主要内容。谢谢大家的聆听。同时呢，非常感谢台湾运动生理及体能学会的邀请这个Climstein 教授来做这个报告。同时也感谢台湾这个国立台北护理健康大学来主办这次会议。谢谢大家。如果大家有什么问题，或者是想与我们联系，考虑进一步的交流合作，可以通过学会跟我们联系。好，谢谢大家。Thank you very much for listening, and hopefully we will develop further exchange and collaboration. Thank you.
Thank you for the That's all right. Thank you for the opportunity to speak at your conference.